information about the audience here. How many of you in the audience are pediatric dentists? Oh, welcome, welcome. Do we have any dental anesthesiologists in the audience at all? Okay, one of the major things in pediatric dentistry in the United States, and I'm sure in other areas of the world, is that although we have a rather dramatic worldwide change in some of the decay rates in children, we still see a tremendous amount of children that have a tremendous amount of dental decay. The title of my presentation, we're going to be discussing the use of office-based general anesthesia provided by the dentist anesthesiologist by pediatric dentists practicing in the United States. This information can help us provide much-needed care for a very young child or a child with special needs with significant dental decay in a safe, humane, and very cost-effective environment. Dental decay continues to be a significant problem throughout the world. The World Health Organization reports that worldwide 60 to 90% of school children and nearly 100% of adults have dental decay or dental cavities. Significant risk factors in children include and remain an unhealthy diet, poor oral hygiene, and social determinants. So again, if you are a pediatric dentist, although this type of presentation clinically is not as common as it used to be, in the special needs population that we see that are medically compromised, and also for children that live in underserved areas, unfortunately, this is a very common presentation that we still see. Pediatric dentists traditionally have relied on self-administered sedation techniques in the private office. The use of general anesthesia in the operating room or an ambulatory surgery center to provide care for those patients not able to undergo treatment in the regular office environment. Now, we have a newly established pediatric dental anesthesia research group at Indiana University in which we're looking into the increase of the number of dental anesthesiologists that are available in the United States to help provide care for this much-needed population. Two of our graduate students have had recent publications in Anesthesia Progress in which they looked at the use of dental anesthesiologists throughout the United States and also their educational program, and then also looked at program directors for graduate pediatric dentistry residency programs throughout the United States to see their current use and their anticipated use for dental anesthesiologists in the future. So just basic results of this is that over 70% of board-certified U.S. pediatric dentists use some form of sedation in their offices. Less than 20% use self-administered IV sedation, and about 20% of these people use a dental anesthesiologist. Unfortunately, because of where their educational programs are located, it's not throughout the United States, but it's fairly much located on the East Coast and the West Coast. And there are some slots in the middle part of the United States that do have these individuals available. One most important thing that we did find out is from 60 to 70% would use a dental anesthesiologist if one were available. Now, does everybody understand what a dental anesthesiologist does? Their training. Okay, we have something going off. Birds flying over or something? That's okay. In the United States at present, there are 10 dental anesthesiology programs approved by the American Dental Board of Anesthesiology. At present, there are 2-year certificate programs, but the trend tends to be going towards a 3-year program. Okay. During this educational process, they rotate through internal medicine, cardiology, radiology, pediatric medicine, chronic pain, pre-admission testing, and intensive care, or PACU. They have extensive management of patients in the operating room in which they do provide either nasal or oral intubation or office-based anesthesia, which it's an intubated, they are not intubated, but they do have, they do use an open airway technique. And this is the main process that we do use to provide care for our children, although if there should be a need arise, they can immediately intubate if they have to. So people always question, especially healthcare financiers always question, are there, why do children have to receive a general anesthetic in order to have their dental care provided? For those of you that have provided care to children with extensive dental decay, we all know how traumatic it can be to some of these children. I know when I was a young child, I can remember the dentist telling my mother, if he acts up, I'm going to slap him. and that was in the middle 50s, although I shouldn't date myself, that was a perfectly acceptable response. Okay, now that's not acceptable under any circumstances. I mean, there are dentists in the recent past and still today that have been arrested for just putting their hand on a child over their mouth. Okay, so we have to be cognizant of the way that we treat patients. So there's a fairly recent study that outlines some of the indications for general anesthetic for children for dental care. Number one, it's children who cannot participate due to the lack of psychological or emotional maturity and/or mental. Well, didn't mean to do that. Required. Let me back that up. I'm sorry. As I said, technology is wonderful. Okay. Okay, so they cannot cooperate due to psychological or emotional maturity and/or mental or physical or medical disabilities. Local anesthesia is ineffective because of acute infection, anatomic variations, or allergy to a specific local anesthetic. Those who are moderately to extremely uncooperative. Anybody that's treated kids, have you ever had those? There you go. Those who are verbally non-communicative or uncommunicative because of psychosocial, medical, or cultural situations. Those children that require a significant amount of restorative or surgical procedures. For those that the use of general anesthesia may protect the developing psyche or reduce medical risk of the procedure to the child. Those who require immediate, comprehensive oral or dental care because of extremely severe dental abscesses, the patency of the airway or other anatomical structures. Or those who have demonstrated the inability to respond to other available behavior guidance techniques. So there is a significant number of children that can greatly benefit from the use of general anesthetic. Okay, now for those of you who have treated medically or just regular children or adults who are medically compromised, it's the ASA classification of surgical risk for individuals that are undergoing a general anesthetic. Now there are a total of 6 classifications, but we're going to specifically identify the first 3, ASA 1, 2, and 3. ASA 4 and 5 are the very severe, very ill patients, and then ASA 6 is when they do organ harvesting after the patient has expired. So for ASA 1, that is essentially a healthy child that has no medical complications, conditions, or contraindications to the procedure. An ASA 2 classification would be a child who has a medically significant medical complication but is well controlled. An example of that would be an asthmatic child who does take an inhaler and is very well controlled, although they do have the asthmatic diagnosis. An ASA 3 patient would be a child or an adult that has either 1 or 2 medical complications that might be controlled or not well controlled. So in our institution and many institutions, most of the surgery procedures that we do on children are done on an outpatient basis, which means they come in the morning of the procedure, they've had all of their consults done, they've had their history and physical provided by the physician, they've received any clearances from any of their physicians to have the procedure done. But so that's ASA 1 and 2. If it's an ASA 3, since it's a child or a young adult that's at significant medical risk, if something should go wrong during the procedure, we have a bed that we have reserved for them in the hospital that in case that they need to be kept overnight, then we can go ahead, admit them to the hospital, monitor them over the evening, and then discharge them the next morning. Okay. Now, our outpatient facility will not let us use an ASA 3 child for an outpatient procedure. We have to do them in the main operating room in which we're prepared for any post-surgical happenings that may present themselves. So if you look at the type of patient that a dental anesthesiologist would use, by their classification, they will treat any ASA child 1 and 2. So that's a healthy child or a child that has a medical condition such as asthma that's well controlled. They have to be at least 2 years old and older. There is absolutely no difference in the preoperative evaluation of the patients done in office-based general anesthesia as this procedure. A complete history and physical examination by the child's physician is completed within 24 hours of the procedure. If there are any consults with cardiology, respiratory, anything that they would have to have, we would obtain a full consult from their primary care physician prior to the initiation of the procedure, so the dental anesthesiologist is fully aware of any possible medical conditions that might arise. If they do have any diagnostic tests that have to be obtained, in the past when I was a young person, a dental procedure in the hospital would be 3 days. We would admit them to the hospital the evening before, do a complete workup. We would get CBC, differential, all the labs that we need. We get a lateral and AP chest films to make sure that the lungs are clear. And now for an outpatient procedure, we do not routinely get any preoperative blood work unless the anesthesiologist feels like that there's a need for it. Okay. So it's a very cost-effective procedure now, but then again, for those of us that have grown up in the past, it's kind of hard to fly by the seat of your pants, but as long as anesthesia is happy, we tend to be happy too. Okay. And then the last thing is that they have to live within the general area of where the procedure is being completed. They can't live 6 hours away. You know, within an hour, if they should develop a problem, they could call us and then we could see them in the emergency room if anything should come up. Okay. Okay, so the three options that pediatric dentistry and really oral surgery have had in providing care for these individuals is in the hospital operating room, in an ambulatory surgery center, which is exactly like the OR. It's extremely well staffed. They have all the bells and whistles that they need to have. Or it can be done in the office as an office-based general anesthesia. Now, for those of you that have provided or continue to provide care for individuals in the operating room, this is what one would usually see. A tremendous amount of equipment. On an academic medical center, we have residents and staff anesthesiologists that help provide the care. We have at least one or two surgical nurses that circulate. We have our own dental assistant that helps us provide care to the patient. This is just another example of an overhead look. This is a typical dental case done in the operating room. At least at our institution at Raleigh Children's Hospital, because we have over 1,200 OR cases a year that we provide, because we're the repository for many of the cases that cannot be done in private practice. They're sent to the hospital. So we have a room that we have that if we have 2 or 3 rooms going, I can sit there and look at the specific room, and they also have all the telemetry for us available too, so we could sit there and actually run 2 or 3 rooms at the same time, and then when it's time for us to go in, we just go into the room, provide the procedure, and then come out. Is there any questions? Okay. Question at the end would be wonderful. Okay, so now what I'm going to spend the next 5 minutes on is talking about a basic financial analysis. Okay, this is not anything, you know, this is not for all the statisticians or people in the audience to think, well, how come they don't have A, B, C, D, or E? We're working on that right now, but this is for anybody in the audience or financial providers or decision makers, whether the care is provided in the hospital or any other environment. Okay, that's good, because this is common sense. Okay, when I go talk to our hospital administrators and state legislators in the state of Indiana and talk to our Congress people about cost of dental care and how we can provide safe, effective, and humane dental care to children, this is what I always talk about. Okay, so again, this is not a sophisticated analysis, but again, if you look at the basic overall information that we'll be talking about, it compares hospital cost. It compares cost of providing anesthesia in the hospital versus a surgery center versus in-base office anesthesia by dental anesthesiologists. Okay, now the 3 venues is in the operating room in a hospital, ambulatory service centers, or surgery centers, or office-based anesthesia. Did it again. This is whoever comes up next, this is a very touchy pad, so be very careful. Okay, now if you look at the average cost, now this is the anesthesia cost and the hospital cost, not the cost for the dental care. This is anesthesia cost, hospital cost. The average cost in the United States, in our area of the U.S., is about $8,000. That's how much the hospital charges. Okay. Now, for those that work with these patients, we all know that there's medical insurance companies that reimburse, and there's Medicare, Medicaid, which is the state dental assistance programs for medical and for dental care. They reimburse the hospital at approximately the 60% level. So if you see the top line, it's 60% is about $4,800. Okay. At an outpatient surgery center, the average cost is about $4,800. And they reimburse at about 60%, and that is $2,800. The office-based anesthesia provided by the dental anesthesiologist, their average cost is $1,250. Okay, and the state, in our state, only reimburses them at about 25% level. So, and the reason that they do that at such a low level is because they have very little experience. They don't understand what they can provide. They think it's just a dentist giving a couple of pills, slap it on some nitrous, and that's the anesthesia. Okay. Well, we're going to go over the specific procedures that they use in comparison to the hospital. So we're going to use the $8,000, the $4,800, and the $1,250 cost for comparison. So between July 2012 and July 2014, I personally did 750 OR cases in the operating room, okay, at Raleigh Children's Hospital. Out of these 750 cases, as you can see, ASA1 classification, there were 326, or 43.5% of children that were treated as ASA1. ASA2 was 248, or 33%. So if you add those together, that is 574 patients, or about 76% of patients were ASA 1 and 2. By definition, they could be treated by a dental anesthesiologist in the office environment, not in the operating room and not in the outpatient surgery center. So about 23.5% were ASA 3s. They could not be treated in the outpatient center. So out of the 750 patients, again, about 76.5% were patients that fell under the classification for office-based anesthesia. Okay, so if you look at the chart here, in the hospital and operating room, if we had done all 574 in the OR, okay, at $8,000 each, there would have been a cost of about $4,592,000. If you look at ASA 1 and 2, if they were done in the ambulatory care center at $4,800 each, the total cost would have been about $2,755,000, or about a $1.8 million savings over the hospital operating room, about a 40% reduction. If you look at ASA 1 and 2s that were done in an office-based anesthesia at $1,250 each, the total fee was $717,500, or a $3,874,000 reduction in cost, or an 84.4% savings. Now, if you're financing state decisions on how to provide care, or federal decisions at the national level in your respective countries, the cost might not be exactly the same, but the amount of savings and the amount of protectivity and the safety of the child, which is always paramount, it's a huge cost savings. So the clinical implications, number one, effective and humane care can be provided for the very young and or medically compromised child with extensive dental disease. You can reduce the potential risk associated with extreme dental treatment accomplished on the very young and or medically compromised child associated with oral sedatives. At present, many dentists that provide sedation give the drugs, they hook the patient up to an EKG or blood pressure machine, have a dental assistant monitor while they're doing the dentistry and monitoring the medical part. And it's a very safe procedure in many circumstances, but when things go wrong, they tend to go wrong very badly. And there are documented deaths every year for oral sedation for children receiving dental care. And again, there's a dramatic decrease in the amount of funding required to provide safe care for these children. So you can provide safe, efficient, humane, and cost-effective care. Okay, as a healthcare provider and as a parent, I want to know what are the risks associated with office-based anesthesia. There's a 2014 study that looked at approximately 37,000 office-based procedures in the United States, and about 22,000 of those were dental cases or GI cases. And complications such as postoperative bleeding, upset stomach, there was less than 1% of those, and there were no deaths reported. Now, there's a 1997 study. This data is much more difficult to obtain. It's mortality of any office-based anesthesia cases that are reported. But in 1997 in OOO, there was an article that reviewed in Toronto the cases over about a 10-year period. They found out that the mortality rate for office-based anesthesia was about 1.4 per million cases. So it's a very safe, very cost-effective procedure. And as a parent with a child undergoing this procedure, that's what I would want to know. Okay, we're just going to take a minute and run through what does a office-based anesthesia case look like. Conference room, we go in, the anesthesiologist verifies that the child has been, main thing is NPO for the previous 8 to 12 hours before the procedure. They're induced, they receive some ketamine, they go to sleep, and then the patient is taken back to the dental operatory, and their propofol is the primary drug of choice that the dental anesthesiologists like to use, a very safe drug. So again, this is just a dental chair, okay, set up for the procedure. Dental assisting work area, it has all the armamentarium that the dental assistant would need. Anesthesiologist has his or her working area. Again, every patient receives an IV. Okay. And then this is the dental anesthesiologist. This is Dr. Mark Saxon. He's a DDS PhD pharmacologist that is a dental anesthesiologist that I do the majority of my cases with. And then the patient is ready. Now, this is not a nasal intubation. This is just a nasal cannula with O2 supplementation. Okay, during the procedure, they receive an infusion that is monitored with an infusion pump for the propofol. Their blood pressure, their CO2, their pulse rate is monitored throughout the procedure for vital signs. Okay, after the procedure is completed, which usually takes us about 45 minutes to an hour. Okay, so we could do 4 quadrants of dentistry. An example would be 8 stainless steel crowns and 4 extractions in a 45-minute period. Okay, the child is completely asleep. We do good work because we're not trying to hit a moving target. Okay, we don't get bit. The child has absolutely no memory of this, so it's a very nice procedure for them. So after they're out, they're taken into the recovery room. We have a nurse present. They're monitored for their blood pressure and everything, just as they were during the procedure. Things that they're looking for is that they take fluids normally. They're starting to wake up. They spontaneously maintain their own airway. They are awake and easily respond. And then if they do need any postoperative medications, whether it be antibiotics or pain medication, that's given to them. The post-op instructions are given to the patient's parents, and then they have our emergency numbers if needed, and then they meet the exact same protocol that they would use if they were being treated in the hospital. These are 122 patients that we did under IV sedation in the office, and you can see out of 122, we had 5 patients, or 4%, that had some type of an upset stomach after the procedure was done. There were 2, or 1.6%, that had a slight peak in their temperature, which is very common after general anesthetic, all below 100 degrees. We had 1 that had a sore throat, and then the most important thing is that out of the 120 patients, none had to go back to the hospital for any postoperative complications. So again, that's a brief overview. The most important thing is that safe, effective, humane, complete care for the child in an extremely cost-effective way for people and for states and for nations to treat these patients. It's a huge cost savings, and these people are excellent to work with. For those of you that are international, if you have not been to Indianapolis, Indiana, or heard of it, we're the 12th largest city in the United States, about 1.8 million people. My university is Indiana University, Purdue University in Indianapolis. We have approximately 33,000 students. This is our new engineering building that's been there about 3 years. And probably most important is that we have the Indianapolis 500, which is coming up. If you've never heard of that, please come. It's a wonderful way to spend 2 or 3 days at lovely Indianapolis. And are there any questions? Or thank you. Any questions at all? Sir.
How do you decide for conscious sedation or general anesthesia? When you decide for conscious sedation in a child?
The question was, how do you make a decision to provide a child conscious sedation versus a general anesthetic? Most of it would be based upon the amount of decay present. If you have one quadrant or something that you could get in, usually we try to limit our oral sedations once we start to about 30 minutes, because the amount of medication, the amount and types of medications that are given can be very, can be very effective. And if you combo them, even with nitrous, you might get an additive effect. So if it's a child that is 3 years old that has a good airway, an airway of 1 or 2, no bad tonsils, they don't snore at night, and they have a stainless steel crown and a pulp to do on primary tooth number A, and they're very apprehensive, they fight, they scream, that would be a good candidate for an oral sedation. That same child that had 12 cavities, requiring 12 stainless steel crowns, maybe pulps and crowns, some extractions, that would be an indication for a general anesthetic, whether it be in the office or the operating room. If ASA 1 or 2, we definitely try to go for the in-office anesthesia, because it's, as I said, it's safe, effective, and very cost effective. Question? Yes, ma'am.
Yeah. No. So how do you actually consider kids with sleep apnea?
Okay, well, we would not do a case with sleep apnea on an outpatient procedure.
Okay.
Okay.
This is what I wanted to
Yeah, oh yeah,
hear.
No.
Okay.
Safe and effective. What's
Okay.
best for the child is that's always what we do.
Yeah,
If there's a history of sleep apnea, again, we would consult the physician beforehand, so we would have a complete history and the effect. Sometimes the mother says, it's sleep apnea, and then they do the test, and they might have class 4 tonsils that they're touching. They have a ENT procedure done 4 to 6 months later, they have absolutely no problem at all. But we would not do a sleep apnea child. Well, I'm the pediatric dentist, I'm not the dental anesthesiologist, but knowing the people that I work with, they would not do that.
Thank you.
Mm-hmm. Okay. Thank you very much. I appreciate it.